Today we have a member of medicine and public health visiting us. So welcome, and let's begin. So Claire Snyder, who is a member of the faculty and professor in general internal medicine and in health policy and management, is with us today. So I sort of remember when Claire came, and she's done a number of things that have really promoted cancer research at Johns Hopkins. So it's really my pleasure to have her come today. As the director of BLOCS, which stands for Building Lifestyle Outcomes and Care Services in Research, Cancer Research, she's founder of that group, so it's very outcome-oriented. But today she will talk about patient-reported outcomes, another area that she has really founded here at Hopkins, as far as I can tell. So Claire, welcome.
Thank you for that introduction, Norma. And I would say that Albert Wu, who is in the audience, probably founded patient-reported outcomes here in cancer. I just metastasized it over to the Cancer Center. I'm really pleased to be with y'all this afternoon to talk about patient-reported outcomes and their roles in clinical practice and clinical research. So who knows what this is? Anybody know what those things are? Kind of. It's a puzzle box. And the way that puzzle boxes work is the way to get inside them is not immediately apparent, but if you can solve the puzzle and execute some pretty complicated moves, you can get inside the box, and usually there's a secret compartment in the box that has some kind of prize in it. And so it's not just the satisfaction of solving the box, but the prize that you're after. So for the purposes of my talk today, I want us to imagine that what is inside these puzzle boxes is information about how the patient is feeling and functioning. And this information is useful in both clinical practice and in clinical trials. The clinical practice box is bigger not because it's more important, but because that's what I'm going to be spending more of my time talking about today. So let's talk about the use of patient-reported outcomes in clinical practice. The clinicians in the audience might be saying, it's fine, I know how to get inside the box. When I go in to see a patient, the first thing I do is I say, how are you feeling? And for many patients, that's probably sufficient for them to tell you everything you wanted to know and possibly some stuff you didn't about their functioning and well-being. But in other cases, patients need more prompting and structure to be able to share with you what they're experiencing. And this is illustrated by this quote from a mother of a child with cancer who says, "When the doctor asks, 'How are you?' and you say, 'Fine,' the doctor thinks he has gathered clinical facts while you think you have been polite." So there can be a role for using a more formal approach to finding out how the patient is doing. And that's where patient-reported outcomes come in. PROs are reports that come directly from patients about their health or disease and treatments without interpretation by a clinician or anyone else, and they are generally collected using standardized, validated questionnaires. And it can be useful to think of PROs in the context of the other kinds of patient outcomes that are out there. When people think patient outcomes, I think their minds almost immediately go to physiologic things like FEV1 in asthma or hemoglobin A1C in diabetes, and then in our cancer context, things like tumor size. There are also clinician-reported measures, such as global assessments, think ECOG performance status. Sometimes there are caregiver-reported measures on things like dependency and functional status. And then there's this whole array of patient-reported outcomes that include global impressions, symptoms, functioning, well-being, satisfaction with treatment, and so on. And it's not that one set of these outcomes is better or more important than the others, but that they provide complementary information. And I think this is really well illustrated by this quote from Atul Gawande's book, Being Mortal, where he discusses his father's experience with a cancer diagnosis. He writes, "As time passed, my father noticed no change in his symptoms. It was ultimately a year before he returned to see the doctor. A repeat MRI showed the tumor had enlarged, yet physical examination found no diminishment in my dad's strength, sensation, or mobility. So they decided to go primarily by how he felt, not by what the pictures looked like. The MRI reports would say haunting things like the imaging demonstrates significant increase in size of the cervical mass at the level of the medulla and midbrain. But for months at a stretch, nothing occurred to change anything relevant for how he lived." And it's not that the MRI was wrong, it's just that it provides different information from what the patient can tell you, him or herself, about how they're doing. And so it's become increasingly common to collect patient-reported outcomes as part of clinical practice, having patients complete questionnaires about how they're doing and feeding this information back to their clinical team. Evidence supports that this promotes patient-clinician communication. It can also help monitor progress and inform management, as well as improve outcomes. So I just briefly wanted to go over some of the evidence supporting the benefits of collecting PROs in clinical practice. This is research that Albert and I did together with Sharon years ago, where we were testing a system for collecting PROs in clinical practice. And patients told us things like, "I think it's a good idea. It helps you remember things that were going on in between treatments that you might have otherwise forgotten." It also gave patients permission to raise things that they might not otherwise have brought up. So this patient reported that she would have never thought to talk about her body image issues with her doctor, but the questionnaire asked about it, and that opened up the discussion about it. And she was glad that she had brought it up because the discussion with the doctor was very reassuring. And while I don't show the quote here, her doctor says, "I had no idea, and I was really glad that we could talk about it." And in fact, clinicians also support the value of the communication the value of the communication promoted by PROs. It helps them identify things like depression that might otherwise have been missed. They also find that it can help engage patients in their care. Sometimes it leads to adjustments in treatment and dosing. And my favorite quote of all time is this clinician who was pretty skeptical about the whole thing and said, "It was less painful than I thought it would be." I consider that to be the greatest endorsement. Beyond promoting communication, using PROs in clinical practice has been shown to improve symptom control. This is a randomized controlled trial that was conducted by Charlie Cleland at MD Anderson that showed that patients who were reporting on their symptoms regularly were less likely to experience what they refer to as symptom threshold events than patients in the control group. This is actually observational data from Ontario that demonstrates more efficient resource use. So in this example, patients who participated in the routine assessment of the Edmonton Symptom Assessment Scale were less likely to end up in the emergency department than patients who weren't participating in it. And those findings were further demonstrated by Ethan Bash's randomized controlled trial, which also found less emergency department use for patients who participated in their STAR reporting system. Beyond resource use, we've seen improved outcomes. So Galina Velikova in the UK was one of the first to demonstrate this, but patients in her intervention group of reporting PROS were more likely to improve their quality of life than patients in the control group. And this finding was also echoed in Bash's randomized controlled trial, with greater improvement seen when you look at any improvement at all, and even when you look at a clinically meaningful improvement of 6 points or more. Beyond improved quality of life, we've seen some results emerge about improved survival. This was a plenary talk at ASCO this year where Ethan Bash presented that in his symptom reporting study, they found not just improved quality of life and resource use, but also that patients were living longer. That's not the only study to demonstrate improved survival. This is a study out of France where they used PROS symptom reporting as opposed to just routine pre-scheduled imaging to follow up on lung cancer survivors, and those who were in the experimental arm survived longer. So clearly there's a lot of valuable information hidden in this box. If only we had instructions for how to find out how patients are functioning. And the good news is we do. And what I want to do in my talk today is highlight several of the tools that are available to those who are interested in this area to help them use PROS in clinical practice and clinical research. In terms of clinical practice, this user's guide was developed by a group of us at the International Society for Quality of Life Research to walk step by step through the process of implementing a PRO assessment process in clinical practice. And rather than identifying one right way of implementing PRO assessment, it provides a range of options, and for each option, its relative advantages, disadvantages, and resource requirements, so that the users can decide which trade-offs work best in their particular clinical context. This is the writing team who developed the ISAQOL User's Guide. It includes both researchers and clinicians from across North America and Europe. And the user's guide was also summarized in this paper published in Quality of Life Research. As I mentioned, the user's guide walks step by step through the process of implementing PRO assessment, starting with just determining what your goals are for collecting the data, and then thinking through which patients and what setting, how frequently, using which questionnaire, administered how, and then on the back end, determining how the results will be reported, how we can aid interpretation of the score meaning, and how we can act on those results to improve patient care, with the final section addressing evaluating the impact of PROS on the practice. I'm not going to go through the whole user's guide today. I wanted to address some of the keys related to administering and reporting on the PROS in practice. So our first key to unlocking the box is collecting the PRO data. If you don't collect the data, you're not going to get very far in getting inside the box. And there are different ways that you can collect the data. You can use paper, which has low entry requirements, but is low tech, and then you end up having to enter the data. It may not be appropriate for all patients. You can do interviews in person, although these are relatively expensive and can lead to socially desirable responses. And what's becoming just the dominant way of collecting these data is by computer. It allows simultaneous data collection and entry. It facilitates graphic score reporting and linking with the electronic health record, although all of this comes up at the cost of very high upfront investment. You can also collect the data remotely. You can do it by mail. This is low tech, but you might not get very many responses, and there's no way to respond to issues promptly. You can do telephone interviews, either with a live interviewer, or if you really want to annoy me, you can have a computer talk to me. And again, what is really beginning to dominate the way the data are collected is the internet. It has all of the advantages of the computer data collection, but allows the flexibility of collecting the data from any site that has web access, although it also adds to the data privacy and security concerns. And some patients may not have internet access, although this is becoming less common. So Albert and I developed the Patient Viewpoint web tool over a decade ago. And Patient Viewpoint is basically a questionnaire delivery device. It's designed to allow clinicians to order questionnaires for patients to complete, much in the same way that they can order lab tests. They can decide which questionnaires, which patients complete at what intervals. When it's time for patients to complete a questionnaire, they can log on to the system and answer the questions, and that has provided the pro data. I'm not going to go into detail about the development and testing of Patient Viewpoint, but these papers that we publish are available. But I think Patient Viewpoint is on the verge of being obsolete, much in the same way as this old cell phone and Betamax. We were one of probably the first to develop an ePro system that linked with the electronic health record. But since that time, there have been many advances in the field that have gone beyond Patient Viewpoint. And in fact, Roxanne Jensen did a systematic review of ePro tools out there in 2014. And even back then, she found 33 unique systems. So the collection of pros is becoming more and more common using these electronic methods. So we've collected the data. Now we need to report it back to get it used in clinical practice. And the ISOQOL User's Guide identifies different approaches for doing this. You can integrate it in the clinical workflow, or you can designate other staff outside of the workflow to deal with it. You can also think about who you want to see the data. Is it just doctors? Is it just nurses? Do you want to also report to patients? Do you want to do some combination of all of the above? And how do you want to report the data? Do you want to use numbers, graphics? Do you want to show just the current time point or trends? So what is becoming increasingly the case for how pro data are reported is integrating the data in electronic health records. And so Albert and I led development of a new user's guide that focuses specifically on integrating patient-reported outcomes in electronic health records. The user's guide stems from several meetings that were held on this topic. Back in 2013, the Patient-Centered Outcomes Research Institute held a meeting on pros and EHRs, and a team of us developed a landscape review of different examples of pros being integrated in EHRs, looking at different patient populations in different clinical settings. There was also a meeting on this topic that was hosted by the NIH Collaboratory in January 2015. And what emerged from both of these meetings was the need for guidance on how one can go about integrating pros in EHRs. And so in response to that, and with PCORI funding, Albert and I undertook a project to provide practical guidance on integrating pros in EHRs, and also thinking about how they can be collected in a way that would enable pooling across systems. In the first part of the project, we put together a steering group who advised us on how to achieve the long-term goals of the user's guide. And like the ISOQOL user's guide, the Pro EHR user's guide addresses a series of questions and topics about integration, and our steering committee helped us identify what those topics should be. We also circulated those topics for comment before we moved ahead, and then we began the process. I wanted to recognize the steering group who helped us with the user's guide, which again includes clinicians and researchers, in this case, solely from the US. And then after making our plan, we actually moved forward and did it. So we identified the writers of each section of the user's guide, people who had complementary backgrounds and expertise in the different topics being covered. We asked them to put together a brief outline and met in person so that everyone could provide feedback on the different sections. They then went home, wrote their sections of the user's guide, which was circulated for comment by both the working and steering group, and then the user's guide was publicly released in May 2017. This is the user's guide working group. Again, a very multidisciplinary group with a range of backgrounds and expertise. And the final user's guide covers these topics. So the main question is, how are you going to link your data with the EHR? Are you going to, some EHRs have pro-reporting capabilities built in. Other ways to do it are build a separate system and then connect on the back end. And then there's a whole range of hybrid systems in between. But once you've figured out your system for linkage, you also need to address things like governance, training, ethical and legal issues, as well as many of the same issues that were covered in the ISAQOL user's guide, but thinking specifically about the EHR's role in identifying patients and figuring out which outcomes to measure and using which questionnaires. So the Pro EHR user's guide is designed in much the same way that the ISAQOL user's guide is, with a list of considerations, and for each consideration, different options and their relative advantages and disadvantages. It also provides case examples, identifies information gaps and research questions, and lists useful references and resources. So the two users' guides are meant to fit together, with the ISAQOL user's guide addressing collection of pros just in general in clinical practice, whereas the Pro EHR user's guide focuses specifically on the aspects related to EHR integration, but ISAQOL was a collaborating partner on the Pro EHR user's guide. Okay, so we've collected the data and we've reported it. What do we do with it? So this is an example Pro measure. This is the physical function domain from the EORTC QLQC30. And this patient reports quite a bit of difficulty doing strenuous activities, a little bit of difficulty doing moderate activities, and no difficulty at all with activities of daily living. And if you go through the EORTC scoring, you find that this patient has a score of 60. Well, okay. Should the doctor be concerned about that score? And this is what we heard, and much of our early research looking at the use of pros in clinical practice is patients and clinicians were telling us, I have no idea if this is a good score or a bad score. And that comes from a variety of issues in the way that Pro instruments are scored and scaled. There's no standardization in it. So for some Pro measures, higher scores are better. For some Pro measures, higher scores are worse. For some Pro measures, whether higher scores are better or worse depends on the domain, such that higher scores are better for function but worse for symptoms. And for some reason, people find this confusing. I don't know why. There's also variation, if that wasn't enough, there's also variation in the way these measures are scaled. So some are scaled 0 to 100 with the best and worst at the extremes, whereas others are normed to, for example, a general population average of 50. And because of this variation, we hear from patients and clinicians, I get confused, which one's higher is better and which one's higher is worse. And a score of 50 can mean completely different things depending on the instrument being used. So at the most basic level, they tell us, I don't know what the numbers mean. The ISAQOL User's Guide outlines a number of ways that can be used to aid interpretation. At the most basic level, you can provide score meaning, at least letting people know whether higher scores are better or worse. It doesn't tell you anything about the clinical importance for a particular patient. At the next level up, you can provide reference scores from the general population, research studies, or other patients in your practice. This provides some basis for comparison, but doesn't tell you what a score means for a particular patient. What can be most useful are measures of caseness, either cutoff scores to identify clinically concerning scores or clinically concerning changes, or putting patients in categories such as no disability, moderate disability, severe disability. This is incredibly valuable, but not available for many pro instruments. And then at the most intensive level, you can review the data with the patients to find out what they were trying to convey to you with their answers. So to address this issue of pro-interpretation, Michael Brundage from Canada, myself, Elliot, and others undertook a 3-part study to look at whether we could develop ways of displaying the pro data such that interpretation would be aided regardless of the scoring or scaling convention. In the first part of this study, we looked at current approaches for displaying pro data and found out what cancer patients and clinicians found helpful and what they found confusing. We then partnered with those stakeholders to develop what we hoped would be improved data presentation approaches. And then in the third part of this study, we tested those new approaches to see how they led to accurate interpretation and clear presentation. I'm not going to go through the details of those studies, but I direct you to these papers with hopefully more on the way soon for those who are interested. What I did want to focus on is the follow-on work that we did, which was to bring together a broader group of stakeholders and conduct a Modified-Delphi process where we took that evidence base that had emerged from our research studies and used that information to develop recommendations for how to display the pro data. This is an example mock-up of what the recommendations would advise. So just to highlight certain things, it's recommended to use line graphs. Patients and clinicians find them to be a very intuitive and useful way of showing scores over time. To deal with the confusion of directionality, in this case, higher scores are better for function but worse for symptoms. There are headers underneath the domain name that explain whether higher scores are better or worse. And we've also separated out the function and the symptoms so they're not mixed together. In addition, it was recommended to include labels along the y-axis to aid understanding of what the scores mean. There was some belief that putting the extremes on the y-axis would be pretty straightforward. We're still not quite sure how to figure out what's poor and what's moderate, but that is useful information when it's available. They also recommended including reference values for comparison populations if available, and providing some indication of possibly concerning results. So it was easy enough for the Delphi panel to sit in the Admiral Felton conference room and say, you should put those things on the y-axis and you should provide reference values and you should indicate possibly concerning scores. But as I alluded to before, we're not exactly sure how you go about figuring out that information. And because of that, Albert, Michael, and I have undertaken a new project that seeks to develop a paper series of different methods that can be used to aid interpretation of pro scores. So we expect those papers to be released in 2019. Okay, so we've collected the data, we've reported it, we've tried to figure out what they mean. What are we going to do to act on those data? So the IsoQual User's Guide, again, outlines a number of ways that you can act on the data. You can train clinicians on score meaning, and over time they might develop intuitive knowledge of, what different scores mean. They can review the score reports with patients to prioritize discussions. If you can link to guidelines, that can be valuable. And the more that we can get the pro data in the EHR with the other clinical information, the lab reports, the imaging studies, the clinical notes, the more that we're able to interpret the pro scores in the context of the patient's other clinical information. So this is the old patient viewpoint score report. It has not yet implemented what we found to be the best way to display the data. But what I wanted to direct your attention to is that on the clinician report, there's a link called What Can I Do? And if you click on What Can I Do, you are directed to these recommendations for different things that you can do to respond to issues on any given domain. For pretty much all the domains, the recommendation starts with a full assessment, and then it offers a range of options from referring to, for example, social work or changing medications, or even just listening and normalizing. The way that we developed What Can I Do was through a targeted literature search and review. And then we identified disciplines with expertise in this area and conducted one-on-one interviews with them and said, from your perspective, how would you help a patient who is experiencing this problem? And then we took the information from the literature review and from the one-on-one interviews and drafted possible recommendations. And then we put all 13 experts in the room. And one of the most interesting discussions that I've experienced in my time at Hopkins, they kind of shared their own perspectives. And it was completely collaborative, where it wasn't like, oh, you should do medication, not listening, but more like, oh, I would never have thought to do that. That's a really good idea. And so these were our multidisciplinary expert panel. This was a Hopkins-specific exercise, and we got input from medical oncology, radiation oncology, patient advocates, as well as social work, nursing, research, outcomes research, palliative care, internal medicine, and clergy. So if you're interested in more details on What Can I Do, it's been published here. But again, just because that's how we went about figuring out how to develop What Can I Do doesn't mean that's the best way or the only way to do it. So as part of our paper series, we're also identifying different methods that can be used to develop these recommendations, not just for how clinicians, but also possibly patients can act on the pro results. All right, so hopefully those keys have gotten us inside the box of how patients are feeling and functioning in clinical practice. I wanted to spend just a few minutes talking about how to get inside the box of how patients are feeling and functioning in clinical trials, because this, again, is a very valuable resource for understanding the impact of different treatments and interventions. So if you ask oncologists, only about 42% feel comfortable interpreting quality of life data from the clinical literature. And 67% would like to be able to do it better. So there's definitely value seen in the data from clinicians. They're just looking to us to help them understand what the scores mean and how to use them. And patients as well are also interested in these data. These slides I've borrowed with permission from my colleague Michael Brundage. And several years ago, he did a randomized controlled trial to find out how quality of life and patient-reported outcome data affect patient treatment decision-making. So he actually, it was done in the context of adjuvant treatment for lung cancer, and what he did was he said, okay, if you have adjuvant treatment versus no adjuvant treatment, this is your survival advantage. Do you want to do the adjuvant treatment or not? And then he randomized them to either see quality of life data that showed very little difference between the two treatments, or a bigger difference between the treatments. And he asked the randomized groups, okay, well, now do you want to do the adjuvant treatment? And what he found, which met his hypothesis, was that the bigger the quality of life differences, the more it influenced patients' decisions about whether they wanted to undergo adjuvant treatment or not. So these data are valued by both patients and clinicians. And when Dr. Brundage asked patients, what were the most valuable things in terms of making your decision about whether you wanted to undertake treatment or not, quality of life, physical, emotional, and cognitive function ranked right up there with toxicity data in terms of influencing the decisions, with survival playing the biggest role. So I wanted to highlight just some tools that are available for collecting pros and using them in clinical trials. So the first tool actually isn't out quite yet, but is expected soon, and it's an extension to the SPIRIT guidelines specific to pros. So the SPIRIT guidelines are recommendations for how to write a protocol for a randomized controlled trial. It says these are the things that you should include. And a pro extension was conducted to identify for the pro parts of your protocol, what are the things that need to go in there. So that should be coming out very soon. Once you've collected the data, you need to report the data. And again, there was a pro extension done to the consort guidelines. So the consort guidelines are the ones that tell you how to write up a randomized controlled trial for publication. And the pro extension identified the key issues that need to be addressed in studies where pros are the primary or key secondary endpoint. And in some cases, it's a new checklist item. So the way this table is set up is these are just the general guidance for randomized controlled trials, and these are this pro-specific guidance. And this is only a part of the table. But the general guidance says you need to specify the objectives or hypotheses in the background. And the pro extension says not only do you need to state the pro hypothesis, you should identify the relevant domains if applicable. In other cases, rather than providing new guidance, it just elaborates on the guidance that's already there. So it says in the general guidance, you need to provide the scientific background and explain the rationale for the study, and the elaboration is don't forget to do that for the pros as well. So the key recommendations from the pro extension were to, in the abstract, identify pro as either a primary or secondary outcome, and the background to state the pro hypothesis, specifying domains if applicable, and the methods provide or cite evidence of the pro instrument validity and reliability, summarize study procedures for pro data collection, and state how you're going to deal with missing pro data, and in the discussion, put the pro findings in a clinical context. The Modified-Delphi process we did for how to display individual patient pro results was also conducted for how to display clinical trial results in peer-reviewed publications. Those results are also not quite out. They exist, they're just not quite out, so keep an eye out for that. So we've now collected the data in the clinical trial and reported them. What can we do to help people interpret the pro data? Well, Albert Wu led a group of us in developing a clinician's checklist for reading and using an article about pros. And conveniently, and frankly by design, many of the same people who were involved in the pro consort extension were part of this clinician's checklist, so that we were asking clinicians to look for the same things that we had told the authors that they should report. And this table just summarizes the items in the checklist. But to highlight the key recommendations or the key questions a clinician might ask about reading a study with pro results is, did they measure the pros appropriately? Did they state the hypothesis, describe their measures. Were they measuring the right things? Did they measure the pro effectively? What was the reliability and validity? Were missing data handled appropriately? Again, this should all be ringing a bell. Does the internal validity of the study lead credence to the results? Were the results placed in a clinical context in a way that will allow me to use them in my practice? And are these results applicable to my patients? So hopefully, the tools that I've gone over today will help us get inside the box of both clinical practice and clinical trials using patient-reported outcomes. The last thing I wanted to mention is that with funding from the Cigarette Restitution Fund, we have been charged, and Sharon is helping me with this, with figuring out whether there is a role for a pro-core within the cancer center. So to do that, we are in the process of conducting a needs assessment to see what value clinicians and researchers could see in having a pro-core, identifying what current resources are available, and then developing a strategy that leverages the available resources, identifies gaps, and outlines a process for how a pro-core might work. The way that we're doing this is to do a needs assessment of clinicians and researchers who are involved in collecting and using pros or want to be but don't know how. And then we're also going to look at how other cancer center cores are organized, how other pro cores are organized at other institutions, and then discuss with the cancer center and institutional leadership. So this is my big plug that our needs assessment survey is currently open. It was circulated by the SKCCC email yesterday. We encourage everyone to participate in it. If you did not receive that link, please contact Sharon. Her email is up here. And we would love to get your input on this. The survey takes less than 5 minutes. I know this because I've taken it like 100 times to pilot test it. So with that, I wanted to express my appreciation to the funders of this research and my collaborators, most especially Albert and Michael, who have been my partners in crime, I think, on every single one of these studies. And with that, I am happy to entertain your questions.
I think I have the microphone on now.
Thank you. I was wondering, one of the challenges you, I think, describe is getting the link between the PRO system and the health record. What are you aware of are the possibilities within EPIC at our institution? Are there any options available for us to use anything that we have integrated, or is that something you're currently exploring now?
So there are possibilities, and it's something that we are exploring. So EPIC does have a built-in pro data collection module. It doesn't necessarily provide all the flexibility that one would want. It doesn't necessarily include all the pro measures that one might want to build, but one of our hopes is through the pro core to have some central system that is available for everyone that will meet their needs. And EPIC is definitely one of the possibilities that would be pursued if we get support to move forward. Albert, I don't know if there's anything you want to add about EPIC and PRO. Albert chairs the School of Medicine-wide task force related to PRO collection in this way. I'm more of a coward. I'm only willing to take on the cancer center.
That's all. And all of the other things that you've taken on, incidentally. I think that Epic and Epic's MyChart and the Welcome portal could potentially be a good way to do this for at least some patients. I think it'll be important to sync things up. The proportion of people who are actually on MyChart and use it is relatively small. At best, for the best department, it's sort of in the 20% range. So a lot would need to be done there too. I think we could have it doesn't have to be either or at all.
Other questions? So Claire, I saw that there are some positive outcomes, medical outcomes from this, and have you developed that further here, for instance, where there is that bundled payment system for hospital care, and the institution really has to manage care in a way that keeps it at that level, and so readmissions, for instance, are a cost to the hospital that they must assume.
So work is being done on that both at a national level in cancer and beyond cancer. So Ethan Bash is doing a study that I'm an advisor on where they're using PROS and feedback performance measures as part of quality assessment that could hopefully improve the quality and possibly, avoid resource use such as readmission. That's not only happening in cancer. Albert is leading a project that's being done in primary care across the nation, and the Comprehensive Primary Care Plus project to also use pro-performance measures as part of quality of care evaluations. So that's a project that we're undertaking with American Institutes of Research, Mathematica, and Bright Outcomes. So we are beginning to see that, not so much in the institution, but more nationwide.
Claire, how you doing? Once again, you've overwhelmed me with your knowledge of PROS. I'm not sure if I missed it in there. What has been done, either by you or others, about PROS from the perspective of the patient in terms of the format of the measurement, the Likert scaling, anchors, anything from the patient perspective in terms of what might be an ideal type of a PRO from a patient perspective?
Well, that's a great question, and
And if I can add one more,
Okay.
and then race and ethnicity, how would those go across different races and ethnicity?
Okay, so both really good questions. So those kinds of things are dealt with more on the development side of the PROS, and again, I've never been ambitious enough to try and develop a PRO measure of my own, but all of those things are taken into consideration both from a patient-centeredness perspective as well as from a psychometric perspective. So a good instrument is developed testing to make sure that patients across races, ethnicities, education levels can understand what the questions mean, that the response options are make sense to them, but also that psychometrically you see distribution across the response options. So that's why developing a PRO measure is a multi-year process if it's done well. But none of the things I talked about today will work if you're not using a high-quality PRO measure.
Hi, Dr. Snyder. Tamara Gray from the School of Nursing. I had a question about individuals who are going across the cancer trajectory in terms of newly diagnosed, active treatment, even end of life, or even palliative care and outpatient, just kind of across the whole health systems and depending on their treatment processes. How would you, or if you've thought about the frequency in which we report patient-reported outcomes so that it is very specific to situations but not overwhelming to patients and families. And then the other question I had was for patients who are who have kind of decisional incapacities and unable to really voice their opinions. How will we really understand patient-centered reporting from maybe a family member or someone else's perspective?
Great. Two other great questions. So the first thing is about coordinating the assessment across the continuum of care and patients' experiences. So I don't know how long you've been at Hopkins. We're a pretty decentralized place. There's pretty much no coordination going on currently. Everyone is kind of doing their own thing. And that's part of the potential we see in having a pro-core is even just knowing who's collecting what when and possibly coordinating and leveraging data and making things more efficient. So I can't say there's any coordination now, except for perhaps within a program like the breast cancer program, who knows what it's doing within itself. But it is something where we see as pro-collection becomes more and more common, the need to coordinate is going to become more and more important. Your second question about proxies, or the answer is proxies, for reporting for patients who can't report for themselves, and this comes up in many different contexts, whether patients are too sick or they're too young. And proxy reporting provides valuable information. It doesn't necessarily provide you the same information that you would get if you were collecting the data from patients themselves. However, what we do find is much greater concordance between patients and proxies on observable things like functioning, but less so on unobservable things like feelings. ISAQOL has a task force that's going to be developing guidance for proxy reporting. So if that's an area that's of interest to you, then keep an eye out for that to emerge.
Do we have any more questions from the audience? Thanks so much, Claire, for bringing this information about the patient-centered outcomes and the research that's going on here. And we'll look for a report in a few years on how it's going.
Sounds like a
Thanks
plan.
again.
Thank
Thanks
you for the
again.
opportunity.